Very good morning. And first of all, I would like to thank the Department of Dermatology, Professor Dr. Satyaki Ganguly, and the team, Dr. Neil Prabha, Dr. Namrata, for calling me here, inviting me here to talk on this, and all the residents who have been actively involved in planning this thing. I believe actual learning takes place at such places where very few people go. And also, as we see the interest generated by the morning speakers, in this presentation or short talk, I will be discussing about the relapse in leprosy. And it is good to see a group of focused people attending this so that our patients will be benefited. So basically the objective of this talk will be what are the definition and the criterias of relapse, how does the relapse presents, how can we diagnose it, and how can we manage or treat it. So to introduce, if we see the numbers with regard to the relapse, that how many actual relapses are getting diagnosed globally. This is the global data taken from World Epidemiological Record. It says around 2,990 cases of relapse were diagnosed from the 10,432 retreated cases, and the number of cases reported from India are 498. As we see, the peak incidence of relapse occurs 10 to 15 years after the completion of treatment. And why we are not having enough studies to supplement the claims that we are finding relapse is because this longer duration that hinders the follow-up studies in this particular area. The DermLab survey that we carried out, it had more than 4,000 patients overall of Hansen's disease, but only 3 patients with relapse were indicated or were noted as relapse cases in that more than 4,000 cases reported by dermatologists. So we can also say why relapse is important, because it is an indicator of success of an ongoing leprosy program and effectiveness of the treatment regime that we are giving, the multi-drug therapy. It could also be a strong marker of drug resistance. So in the context of relapse, it is important to learn and study this slide, because relapse, it is diagnosed after patient has been RFT'd. And these are the post-RFT events which we should be aware of, that we are not mixing the post-RFT natural occurring events with a possibility or plausibility of relapse. So we found that more than around 21% of patients, they had active skin lesion even after successful completion of RFT. 14% of patients, they had neuritis. 13% they had ulcers. 11% had deformities. We get early and late lepra reactions as well. 6% of them had recurrence of symptoms, and few leprosy patients, about 20% of them, they come back to us for reassurance. Many a times, as the morning speakers have elaborated, they become dependent, or they psychologically dependent on multi-drug therapy. They think that if I don't take MDT, my disease is going to worsen. But as we see, even after completion of MDT, our body's own immune system tries to clear the bacilli, and there is a gradual improvement. So then most of them, they come to us for reassurance. So these are the scenarios which we should not confuse with possibility of relapse. First, we should try to exclude or rule out these naturally occurring incidences so that we don't label them as relapse. So it is important to understand that there are 3 criteria in the definition of relapse. First is the patient must have successfully completed full course of standard multi-drug therapy treatment as per his or her baseline PB or MB status. And the patient should be presenting to us after the defined surveillance period. That is 2 years for PB cases and 5 years for MB cases. After this, if the patient is presenting to us with signs and symptoms of disease which are not seem to be due to lepra reaction, then it is defined as relapse. So this is kind of a definition of exclusion. First, we make sure that patient has taken sufficient MDT. If patient has not taken, the question of relapse is out from there. Secondly, we judge whether it is during the surveillance period or after the surveillance period. The surveillance period for PBMDT, it is 2 years. Some authors mention them as 3 years. And for MBMDT, it is 5 years. So with this definition in mind, if patient presents to us with this clinical and laboratory criteria, then we define it as a relapse. So what are the clinical criteria? The first being reactivation of pre-existence. That reactivation means the expansion or enlargement in the size, or the nerves which were previously involved after successful completion of MDT, they had become, and again a new sensory loss is developing, suggestive of a nerve involvement. That is reactivation of pre-existing lesion. Just understand that this reactivation does not mean reaction in previously treated or pre-existing lesions. Secondly, the new areas of sensory loss or altered sensation, which suggests the new nerves are getting involved. And thirdly, any new neural alteration, evolving lesions or symptomatic outbreaks which do not respond to treatment for lepra reaction, including other inflammatory treatment. So these are the clinical criteria. And when patient presents with this clinical criteria, we apply a laboratory criteria, we work them up. For slit skin smear, if that shows solid stain non-granular bacilli, that again this suggests the possibility of live bacilli, then along with that, if there is persistent or higher bacillary DNA load in quantitative PCR test, or if the screening of this test is available where raised or persistent anti-PGL1 ELISA antibodies, if we find, this makes up the laboratory criteria for diagnosis of relapse. So what are the predisposing factors to the relapse? This is the monotherapy, which is not now practiced, but patients who had received monotherapy before, say before 20 to 25 years, they may come to us with signs and symptoms of leprosy, and they are the ones who are more likely to have relapse. Reinfection, it is very difficult to differentiate whether it is a relapse or reinfection, because we do not have that advanced molecular studies available which differentiates what was the strain of M. lepra at the time of initial infection and now. So it is difficult, but if there is an active MB case in family, continuous re-exposure or reinfection from that person may give rise to relapse. Drug resistance is an increasing phenomenon which is occurring. Dr. Pugal would substantiate that, which is increasingly diagnosed now in patients of leprosy. There is a drug surveillance program going on. There is also a cell for it. And now it has been seen in India, about 9.6% of patients, they may be having drug resistance to anti-leprosy drugs. Irregular treatment, the recurrent and chronic ENL, high initial bacillary index, and any other immunosuppressive conditions like HIV, it may be predisposing patients to increased chances of relapse. If we understand the immunology, this entire study about immunological aspects in leprosy is now picking up. And they're trying to find answers to all the questions like why certain patients are getting recurrent ENL or chronic ENL. What is how the immune system is behaving differently in patients who are having relapses. So this is one of that kind of study who had enrolled more than 20 patients, and they compared the immunological profile of patients who had successfully completed MBMDT and those who had developed relapse. And then they found that this relapsed MB patients, they do not produce enough interferon gamma in response to M. lepri. There is inhibition of CD86 monocytes and dendritic cells by M. lepri significantly increases in relapse. There is also predominance of the central memory CD4 and CD8 cells in leprosy relapse. So what is occurring is this memory cells, they reside in our skin, and at the site of pre-existing lesions, they again get reactivated later on, and they lead to the formation of activation of the new lesion. So this M. lepri, they induced significantly higher levels of interleukin 1 beta, interleukin 6, and TNF alpha among relapsed patients. So these are the immunological changes occurring in an individual, which is predisposing it to the development of relapse. So clinical features, like I described in the criteria, these are the main clinical features. So new skin lesions in lepri patient probably occur either due to reaction, which I'll be discussing next. So what happens, there are two types of reactions, early and late, after completion of MDT. So whenever patient is presenting to us, first we need to rule out that these symptoms are not that of reaction. And the reaction can be either type 1 reaction or type 2 reaction. So we need to differentiate whether this is a reversal reaction or early type 1 reaction or an ENL vis-a-vis clinical presentation of relapse. Drug resistance is also one thing which we should keep in mind. This is basically therapeutic or clinical ineffectiveness of MDT, which we get to see in certain subset of patients, and in whom we should work up for the drug resistance. So if we compare relapse with late reactions, firstly, the relapse should satisfy this criteria that patient has been treated as per the WHO recommendation adequately. In the reversal reaction, patient may present de novo, may or may not have received any adequate treatment. We have a history of clinical, bacteriological and histopathological subsidence on taking adequate MDT, and then patient is presenting. While in case of reversal reaction, the clinical presentation may be ongoing. The onset is insidious in case of relapse, while in reversal reaction, it is usually acute and severe. In relapse, the involvement of older lesions in terms of increasing the size of pre-existing lesion is more likely, while in reversal, they become more tender and inflamed. There are no systemic signs and symptoms of reaction in patients with relapse, while in reversal reaction, we get to see the constitutional signs like fever. Neuritis is less common. It is just the nerve function impairment without neuritis in patients with relapse, while in case of reversal reaction, there will be neuritis. Histopathological differences are also there. The relapse, it would respond to the multi-drug therapy alone, while we require anti-inflammatory medications for reversal reactions. And the relapse, it would not respond to the anti-reactional treatment, while the reversal reaction will show a dramatic response to the corticosteroids. Similarly, the clinical criteria, they remain the same when we want to differentiate it from the ENL nodules. The only difference here would be the initial pole of leprosy. It's usually seen in lepromatous patient, lepromatous leprosy and borderline lepromatous leprosy. The onset, the constitutional symptoms, it will also be similar like the previous one. Here we know the type of clinical presentations of ENL, which in the morning sir also described. It could be ulceronecrotic, it could be pustular. So that is how it would be different from the clinical presentation of relapse. So this thing we should, what I'm trying to stress again and again is that we should first rule out reaction when we are suspecting a patient with relapse. This slide I will come back slightly later on. How are the histopathology different between the relapsed lesion and the baseline or the newly diagnosed cases of leprosy? Here in histopathology, we get to see the signs of previous treatment in form of presence of foamy macrophages will be there in case of MB leprosy. And Along with formy macrophages, if we are getting to see any new form spindle-shaped macrophages, that would give us the clue that has been previously treated, but now showing active signs of histopathological signs of relapse. So this slide also I'll come back slightly later. So this is what I want to again stress. Whenever the patient presents to us, first we will adjudge whether the patient is presenting to us within surveillance period or not. So that would be our first checkpoint. If patient is presenting to us within surveillance period, most likely the relapse goes out of the question and we will check for the lepra reaction. If the lepra reaction signs and symptoms are also not there, but there is still a possibility, then we have to investigate for the relapse, or there is therapeutic inadequate response in those cases when it presents within the surveillance period. And if the patient is presenting to us after the surveillance period, then we investigate for the relapse based on the clinical and laboratory criteria, and then we make the further diagnosis. So this is one such flow chart that we should follow in our clinical practice, that what was the initial form of presentation of the patient, if it was pure neuritic leprosy or borderline tuberculoid ambileprosy. We inquire about the previous treatment. It was a standard 12-month MB-MDT. We look for the surveillance period. If it is less than 5 years, we rule out the reactional episode. Then still we are suspecting, then we label it as a therapeutic failure. So clinical condition or specific tests are altered. Then we label it as a therapeutic failure and not as a relapse when patient is presenting to us within the surveillance period. And we work up such patients for resistance or for inadequate response to MB-MDT in this subset of patients. On the other hand, if it is more than 5 years and the clinical tests are altered, then we diagnose it as a relapse. If it doesn't show those conditions, then we keep them in follow-up for longer duration. Again, that was for the pure neural and tuberculoid. It is similar for mid-borderline, borderline lepromatous and lepromatous. Here also, if it was borderline tuberculoid and we treated with 12-month MB-MDT, we will label there as therapeutic failure. Here we are labeling it as therapeutic insufficiency, and we will again give 12-month course of MB-MDT. That is the difference that we need to make sure what was the primary diagnosis, which pole patient belonged to. It was a paucibacillary patient during the surveillance period presenting to us therapeutic failure. Mid-borderline to lepromatous pole had received only 12-month treatment. Here it is insufficiency. We would again give 1 year of MB-MDT and then re-evaluate. So that should be the flow chart or the SOP for such patient. For more than 5 years or after the surveillance period, the algorithm remains the same. So I will just present here some 2 or 3 examples of such patients which presented to us. So this lady, 32-year-old female, presented to us with tingling and numbness over hands and feet. She also developed recurrent non-healing ulcer over right sole and left little toe for last 6 to 8 months. We did dressing and she improved on dressing. She had a history of unnoticed trauma over feet and hands and slippage of footwear. Patient was initially diagnosed as borderline lepromatous leprosy with type 1 reaction, and she also had grade 2 deformity because of the presence of plantar ulcers that categorizes as grade 2 deformity. She gives loose history of receiving 12 to 18 months of treatment with MB-MDT before 3 years as per the records available. So here in this case, it is initial diagnosis was borderline lepromatous. She had took MB-MDT for 12 to 18 months before 3 years. So basically, this suffices for therapeutic insufficiency. We worked her up for the laboratory parameters to see if there are any active live bacilli are there or not. Slit skin smear showed 2 plus solid bacilli. So we again gave this lady 1 more year of the standard MBMDT, and we will re-evaluate afterwards. This is another slightly more confusing case, because this male, he has complaints of redness and lacrimation in both the eyes since last 10 to 12 years, basically ophthalmic complications of leprosy. Recently, he has developed tingling and numbness over both hands and feet since 2 years. He gives history of dry ecthartic patch and loss of sensation over skin lesions of upper and lower limbs since 6 to 8 months. And he has also developed some discoid red itchy lesions over both forearms, thighs, and legs since last 2 to 3 months. So here the history goes back as long as 20 years. He has received 12 months of MB pack from Kolkata 20 years ago. So he does not have papers available for what was the baseline poll at the time of diagnosis. So see, we cannot go back in past and change the records, but now this should be a learning for all the PGs here, that whenever any leprosy patient, a new case of leprosy patient is coming to you, that is very important time point in the life of that person. If you document your findings perfectly, then over the course of say next 20 years, 25 years, 30 years, the other physicians, they will rely on those findings. So you have to document correct findings. You may feel like, do I have to palpate all the nerves? If you have documented properly, palpating all the peripheral nerves, then only we can say after 5 years whether there is any new nerve involvement or not. If there is no baseline document, with which will we compare the new onset neural involvement? So that is the most important time point, and that should be the take-home message for all the PGs, that when the first time you are encountering a Hansen's patient, document every finding perfectly, because that is going to shape the lifetime treatment of that leprosy patient. And other physician, dermatologist, wherever that patient will go, is going to have this. And if we get electronic medical records, which government is trying to bring now with digital health records, that should be a game changer for leprosy patients. Because if that is available to you, most of your queries with regard to whether it is reinfection, relapse, reaction will be answered. Why we are struggling is because we don't have baseline documentation. What has happened with patient, what has patient consumed, we don't know adequately. And that is why we are not very clear. So here he had received it 20 years back. And as we see, there are few ecthartic lesions. There are also scaly lesions. If patient has developed papillosquamous lesions, scaly lesions, and they are itchy. So we worked him up. As we see on the lower limbs also, they are, some of the lesions are discoid. We can see also the scars and the depressions, previously hidden scars of maybe he had undergone a very necrotic type of ENL. And we see on the sides of the legs changes suggestive of stasis, dermatitis, or eczematis. So basically, the patient is showing symptoms suggestive of slightly eczema in all the patches. So we should also not forget the residual effect of nerve involvement of leprosy. That will, those autonomic effects, it will not completely go, and patient can present with some other dermatosis or such eczematous dermatosis. On the nerve examination, patient had this many nerves which were involved, but we did not have any baseline documentation, so we cannot compare the baseline, or we cannot compare with anything. Sensory examination also showed some nerve function impairment or the deficit. And so is the motor examination. But on working up the nerve conduction studies, they were giving or showing the involvement of the nerves they were suggestive of. Histopathology, it was not suggestive of histopathology of relapsed lesion, as the histopathologist was very senior and a respected one for the leprosy in our country, authoritatively said that there are no findings suggestive of relapse. Dermal nerves are free of inflammation. There is no any active ongoing granuloma. Spatial stains, they were also negative. DNA PCR also we did because we did not want to miss the case of relapse because it was more than 20 years. So that also came as negative. And slit skin smear also did not show any acid-fast bacilli. So what is in our hand is to do these 5 things if we are strongly suspecting relapse. And based on that, we can either retreat the patient, or as of now, what we are doing this patient is treating for the eczematous part, giving him symptomatic treatment for the eczema and keeping him in observation for say development of another lesion. So the clinical possibilities in this patient was post-RFT complications of leprosy, and because this many nerves were involved, could be a neural relapse. But we hardly find any mention of neural relapse in our solitary neural relapse in the medical literature documented till now. So these were the clinical possibilities which we should be open to. Now moving on to the management, I will just summarize it briefly, because where we have suspected therapeutic insufficiency, there we will work patients for the resistance. It was here. Right? Where there is therapeutic insufficiency, there we will work the patient for resistance. The causes for resistance could be due to adaptation of organism. There may be initial response followed by immediate worsening. With ongoing MDT, there will be appearance of new lesions, and usually it is a downgrading type of event. Drug resistance, what we know so far from the genetic studies which are available, these are the genes which are implicated in the development of drug resistance, and they could be diagnosed with an in vitro test. But as we were discussing yesterday, these are all in vitro and no in vivo. Mouse foot pad assay would be the ideal one for suspecting, or when we are strongly suspecting resistance, but the assays, they are not suggesting the positive test. So in those cases, in vivo methods would be helpful. So based on that, in drug susceptible individual, we would just continue, or we restart the conventional MDT for a sufficient duration. Especially in case of suspecting relapse in PB patients, we should be more vigilant before reintroducing MB-MDT, because that classifies as therapeutic failure and not insufficiency. And this is a universal fact that no MB patient should be treated as PB patient. Most of the times when we diagnose a relapse, always treat for MB only, and as such there is now uniform MDT. So we should implement that only for all the relapsed patients. Now the treatment of drug resistance, where we find drug resistance, it is if there is resistance to dapsone, then what we give is the monthly supervised dose of rifampicin clofazimine. Now this is if there is a resistance to dapsone, we just omit the dapsone. We don't add anything else. We keep everything the same. If there is resistance to rifampicin, then we categorize, or we differentiate it between an intensive phase. Therein, we give daily any of these two, either clarithromycin, minocycline, or quinolones, and during the maintenance phase, daily, either one which we had given before. So if we have given clarithromycin and minocycline before, we continue any one of them during the maintenance phase for the duration of 24 months in combination with daily clofazimine. As of now, we do not have any resistance to clofazimine, which has been laboratory documented. 1 or 2 case reports are there, which may suggest clofazimine resistance. The loci has been investigated and found, but in actual patients that resistance is not still validated. So clofazimine has a place for treatment of resistance in all daily clofazimine in all patients. If patient has resistance to both rifampicin and ofloxacin, these patients, they will be getting intensive phase daily clarithromycin and minocycline, and either of this drug during the intensive phase. So this would be the treatment of relapsed patients with drug resistance. So to summarize, what are our practical problems is that we do not have the proper baseline investigations and records. Also, the follow-up is very important. We do not have objective monitoring of this patient. And whenever there is variability of inter-observer, variability is very high. I may palpate some nerve, you may not appreciate that nerve as being palpated. So that subjective monitoring is also there. And there are very few serological methods which are readily available or available at bedside for diagnosing or confirming the case of relapse. And the limitations, they get aggravated when we go into the field because there is unavailability of any such screening tool. So what we have been discussing is the current knowledge gap on the subject of relapse and the possible recommendations that we can do in the future. That would be molecular screening of all newly diagnosed MB cases for primary drug resistance, and all the close contacts of drug-resistant leprosy should be screened for transmission of the resistance strain. That would be most important way going forward. Taking the long incubation period, Dr. Pugal says it is about 100 years, so long-term follow-up or even still the patient dies should be followed up for the surveillance. At least once in a year for early detection of relapse. Hope this was informative and helpful for you, and it will give you some impetus or clarity in the patients where you are suspecting relapse. These are the references, and thank you again for inviting me here. At this, I'm coming to Raipur for the first time, so thank you so much. Right? We need a clearer mind to reflect on something positively. So still waters, we can reflect properly. Thank you.